Okay, everyone. Good afternoon. Thanks for being right on time. It's so nice to see so many of you. And I know more are continue to roll in, so we'll give them a minute to do that. But uh, I see some familiar faces, many new faces. I just want to welcome you to today's Peer Support Learning Collaborative. I'm Barbara Fain. I'm the Executive Director of the Betsy Lehman Center for Patient Safety. As some of you know, but some of you may not know, the Betsy Lehman Center is a Massachusetts state agency. I like to say, the only state agency named after a person. But we do a variety of work to promote and support others' efforts to improve safety in healthcare, and including convenings and research. And we have several programs, including our peer support program, which provide really, I think, meaningful technical assistance to hospitals, other healthcare organizations, and to support them and to support patients and families in healthcare. So today's session is going to focus on methods to combat workplace violence in healthcare. We know that this topic is very much top of mind for folks who work in the healthcare space, or really anyone, which is pretty much all of us in the healthcare space. So we're really delighted to bring this presentation to you now. We have a great program in store, so I'm going to get right to it by passing the baton to Linda Kenny, Director of the Betsy Lehman Center's Peer Support Program. She will tell you more about today and introduce our speaker. Linda?
Thank you, Barbara. Hi, everyone. My name is Linda Kenny, and I'm glad you're all here today. Today, we're excited. We had 100, well, it's not 100, sorry, 400 and I think it's 80 now, right? Whitney, people sign up for this. So we know it's an important topic to everybody. So just, we're going to have our presentation with Tyler, and let me give you a brief description. Hang on one second. So Tyler has been involved with healthcare safety and security since 2016, where he currently holds a position of workplace violence prevention manager through Lowell General Hospital. Tyler he also coaches Tufts Medicine System Workplace Violence and Prevention Committee that strategizes and implements progressive approaches for violence reduction in a hospital setting. In addition, he has a master's level instruction for workplace violence prevention and home health care, and instructs other courses specific to behavioral health and active shooter response. So I want to thank Tyler for being here and being willing to do this. So after his presentation, we will have a Q&A, and we thank you for all your pre-questions, because that's helped Tyler figure out where he'll go with this presentation. And then we'll close. But after we close, we will be sending a survey, and we really want your input, because we want to know what topics are important to you, so that we can get appropriate speakers for the next one that we'll have in a couple of months. And I'm going to hand it over to Whitney.
Thanks, Linda. I just want to quickly go over how to add closed captioning. This is available during this presentation, so if you would like to use it, you can enable that on your own Zoom screens. At the bottom of your screen, depending on the version of Zoom that you have, it might show something different, but just look for the CC button, the show captions, or live transcript buttons. You may also have to click on the more button, which is those three small dots. Then click captions, and then you can select your preferred language and click save. Those captions should then appear. But if you have any questions or you need any help with that, feel free to reach out directly to me. And I will pass it back to Linda to introduce Tyler.
I'm just going to turn it over to Tyler so he can get started, so we can get to the meat of the program. Thank you, Tyler, again for joining us.
Great. Thank you guys for the introduction, and appreciate you having me here. And again, huge thanks to everybody who was able to register and log on to join today. I know personally it's a really important topic for me. I've been personally affected by it. A lot of friends, family, coworkers have also been affected by workplace violence here. So I really genuinely appreciate you guys taking the time to really take the time out of your busy day and busy week to join and talk about some of these topics. So really what we're going to go over today in a fairly short amount of time is really looking at progressive strategies to combat workplace violence in healthcare. And when we think about healthcare, I mean, my background is in a hospital setting. I work at Lowell General Hospital, bounce back and forth between both campuses that we have. We also do a lot of systematic work throughout Tufts Medicine as well. But under our umbrella, we also have private practices, urgent cares, that really all fall under the scope of workplace violence. So a lot of the strategies and tips and tricks that we'll discuss today really, really can be utilized in all of those spaces, not just the overarching hospital setting.
Thank you.
So starting out, I always like to bring up this American Hospital Association. If you guys haven't seen it, put out a really, really interesting report last year, or sorry, 2 years ago about 2023, and they looked at the financial impacts of workplace violence in healthcare. So they summed it up in healthcare to be $18.27 billion spent on workplace violence. What's really interesting to me is looking at the allocation of funds listed below with regard to pre-event costs and post-event costs. And I know personally, I can speak to this, that there is some validity to the actual data here. But looking at where you have the funds that are spent, and I think a lot of us kind of fall victims to this as well, right? Where we have these great ideas on proactive strategies and mitigation strategies that we can implement beforehand. However, oftentimes we get that unfortunate narrative that it takes a big incident for us to spend money, which the data kind of shows that looking at the allocation pre-event and post-event. So a lot of what we tried to do and implement is really, really focused on that pre-event cost. We work with a lot of leadership here, and the general consensus is it's okay to spend money pre-event, but it really becomes challenging and difficult when you're relying on that post-event to play catch up after an incident. So I always like to bring that up to cue it up. You guys hit the introduction pretty well, but this is me again. I'm the workplace violence prevention manager through Tufts Medicine and Lowell General Hospital. I've been working in public safety and security since 2016. With that, there's been a lot of roles I've taken on. There's been a lot of things that I've done and experienced, which is really nice that the information isn't really coming from the textbook. A lot of it comes from just experience, right? And how we can take some of that information and actually make legitimate and effective change at the hospital. So one thing that always drives me, especially since I've taken on the role of workplace violence prevention manager, is just a really vague statement, but how can you keep people safe, right? There's a lot of strategies that people think about. Some work, some don't, but it's really looking at your specific organization with that goal of keeping people safe. And it's, our staff, it's yourselves, right? Keeping yourself safe, both emotionally, psychologically, but also physically, looking at our patients and visitors and families as well. So it's really that overarching idea of how can we just keep everybody safe. I always like to pull up a little bit of data. Here at Lowell, we categorize workplace violence pretty specifically. And with that, we have the opportunity to pull data year after year, looking at some of the strategies that we've implemented, seeing if it actually makes an impact, and if it doesn't, seeing why. Looking at last year, so 2025, we had 622 reported incidents of workplace violence across our system, which is 2 primary hospitals, but this also includes all of our offsites as well, with regard to primary care, private practices, and urgent cares as well. So 622 reported incidents. Within that, and I'll talk a little bit about our high-risk areas, but we determined year after year that our 2 emergency departments and Sullivan 1, which I'll discuss in a bit, but it's our psychiatric ED, are primarily our high-risk areas where we see the most amount of violence in the ED setting. So within the last year, we saw a fairly drastic and significant decrease in workplace violence based on some of these projects we're implementing. Our main campus emergency department has 49 beds plus a handful of hallway beds. I think we have a capacity of over 100 in our main campus emergency department. Saints Campus ED is a little bit smaller, However, we do have a very different clientele and patient population that comes through those walls. It's located in downtown Lowell. So we've seen a 25.3% decrease there. And then what is really great to see is our psychiatric ED in Sullivan 1, where we saw a 51% decrease in workplace violence incidents. Looking at drilling down a little bit more deep into that, within those incidents, we saw a 11.1% decrease in completed assaults, an 11.6% decrease in attempted assaults, which are fairly significant considering the numbers that we do see. Closely in alignment with that, we also saw decreases in restraints, and you can see the numbers down here below, but ranging from physical restraint all the way up to that mechanical 4-point restraint at the bedside. Looking at our staff as well, we always try to look at those numbers and compare those data year after year. One of the biggest things that we try to target is reducing injuries and supplemental lost work days. So again, last year we saw a 55% decrease in lost work days in our employees, which has been phenomenal. And then finally, looking at education and training, we were able to hit over 1,000 employees educated in workplace violence throughout the course of the year, which has been really, really great. So again, just queuing it up with a little bit of data and positive outcomes that we've had throughout the past year. So as we go through today, there's all types of topics we're really going to discuss, but really to develop and implement a really effective workplace violence plan, we break it up really into 5 fairly simple pillars. Number 1 is leadership evolution, and we'll go into these more in depth, looking into interdepartmental collaboration, training strategies, program enhancement, and then finally, staff support. As we go through this, we're going to look at each of these pillars individually and really break down specifically what you can do within them to actually implement a positive change. Starting out, we'll talk about leadership evolution, and this is one that really, really has hit me personally, and the organization. We've seen some really great positive impacts based on leadership evolution. So looking within your organization, really hitting on that directed leadership position, specifically when it comes to workplace violence. So throughout the course of today, I will pose a handful of rhetorical questions. This is nothing that you need to put in the Q&A, nothing you need to put in the chat, just something to think about when it comes to yourself, your organization, and where you guys are at currently. So number 1 is just understanding who oversees your workplace violence prevention program. Do you have a workplace violence prevention program? And if you do, who oversees it is a really, really important thing to recognize and look at and dig deep into. So looking at the dual role model, which again, I've spoken with quite a bit of folks across the state, regionally, across the greater New England area, across the country, and looking at who oversees your workplace violence prevention program is really interesting to look at. It's a fairly new development, I guess you can say, within healthcare. For years, you always managed workplace violence, but it was never really had the spotlight that it has now, which is it's twofold, right? It's challenging that we have to put a spotlight on it because it's that prevalent, which is unfortunate. However, it's great that we're actually finally able to look at it and give it more of a specific allocation of funds and resources that it actually needs. Historically, what a lot of organizations and hospitals do is you have that type of dual role model. And this isn't specific to workplace violence prevention, but it certainly falls under this category where you have somebody who their primary role is not workplace violence prevention. It's something like a public safety leader, whether it's a manager or a director, somebody that falls under public safety and security as a side role, we'll say, is voluntold or given the workplace violence prevention program. We have to have a workplace violence prevention program. You have to have a committee. You are the one that's going to oversee it, and it's just added onto the plate of their primary role and their primary focus. Some organizations have nursing leaders. Risk management is a fairly common one as well, that's their primary role, but they also are given workplace violence prevention on the side. And there's a handful of others that typically would fall under as a secondary role. For us, I know we fell under this for quite some time up until recently, but you had the public safety leader. At the time I was working as the public safety manager, and it's really hard to allocate the resources internally to manage a public safety team and do your day-to-day and your scheduling, your resources, and your employee relation issues, and actually dealing with the operation side of your job. And then on top of that, give the workplace violence prevention program the attention that it actually needs. But that's where a lot of organizations fall. So with us, this is circa 2023. In my role, again, as public safety manager, managing also the workplace violence. These are the projects that we were able to implement for workplace violence. And it was really interesting to take a look back. And it's really the bare bones minimum, right? It's doing your annual policy review and revision that you need. It's doing your site assessments that you need. It's doing some sort of training, right? To what extent you can do training really depends on your job and your schedule, which sometimes can be really challenging. And then maybe an extra project here or there on top of running your committee. So overall, you can put out a couple of projects, you can give it a little bit of time, but it's really not giving it that full dedicated resource that it needs. So now cut to 2024, where we really looked at the role, and we looked at workplace violence as a whole and the resource that it actually needs. Organizationally, we made the determination to get it a fully focused position, implementing my current role of workplace violence prevention manager. It actually started off as program manager, but actually we're getting more roles under the workplace violence prevention scope. So it's almost a little sub department, which is really cool and really interesting to see. So looking at Joint Commission, I don't know how many of you fall under the Joint Commission accreditations or anything, but they do have a handful of standards that you need specific to workplace violence. And one that's really interesting, and you can dig into this however you want, and you can really curtail your understanding of it differently, but it reads, and verbatim, the hospital has a workplace violence prevention program led by a designated individual to develop by a multidisciplinary team that includes the following, and it goes on to list a handful of things. But one interesting thing to call out, and especially if you're interested in pursuing a dedicated workplace violence prevention position, is that language where it says led by a designated individual. And it gets really challenging to make the case sometimes for that designated individual if that's not their designated job. So if you're looking to make a case where this can be a really good backer for it, saying we're just really meeting the Joint Commission standard to the best practice that's available. So 2024, we were able to make the shift and again, implement the role of workplace violence prevention manager. And it's really interesting looking back at some of the projects that we were able to implement over the course of a year and 2024 and 2025. We'll talk about some of these initiatives as we go through, but there's quite a bit that we were able to implement when you have that dedicated focus and you're not dealing with the operation sides of another job, right? Like this is the job, to look at the problems, identify issues, find solutions and implement said solutions. So it was really interesting to go back. And again, we have 2 pages of them and the list continues to grow, which is really wonderful. But having the time, the energy, the resources to actually look at workplace violence and find out what the problem is as a primary focus and then find solutions based on it. So I know just looking back for me, it was fairly eye-opening looking into some of the projects we were able to implement in such a short time. Speaking anecdotally here, I know that it was kind of difficult to make the case, right? Yes, we have this idea, we have a need, we have identified problems that workplace violence is a legitimate issue, not only just locally at our hospital, but regionally, statewide, across the country. We know workplace violence is an issue. Making the case for a dedicated position can be fairly challenging, even though we know what the problem is. So a couple things that helped us really, quote unquote, make the case is understanding that it's really that shift in healthcare best practices that this is going to be the standard. And I'm saying that anecdotally, but I truly believe that this is kind of the way of the future, where a lot of hospitals now are jumping on the proverbial bandwagon and getting somebody who's dedicated to workplace violence as a primary role. So understanding that that's kind of the shift that a lot of hospitals are moving towards. A couple of years ago, maybe there was a handful across the country that held a workplace violence prevention position. But interesting, I was doing some training up in Maine not too long ago, and they had already just implemented a workplace violence prevention manager, which is really cool to see that it's kind of becoming the standard. which is really nice. So looking at, okay, industry best practice, we know that. What type of data do you need? What helped us is looking at our local data. So across our hospitals, the amount of incidents we see, the types of incidents we see, any type of tracks or trends that would really be prevalent and useful. You can use state data. I know for those of you in Massachusetts, MHA has a really, really phenomenal report that they pull annually on workplace violence prevention. You can take that information, some national data, like I had mentioned through the AHA, that put out the financial impacts of workplace violence, taking all of that data and compiling it into some sort of report and trying to push for this position. What really, really helped us is that representation of realistically what people are going through, right? So you can say, yes, we've had 6 threats this past week. What really tells the tale is hearing, and I'm talking whoever you're making this case to, is hearing words of the people involved, right? Hearing them that say, yes, I was threatened, but this is exactly what the individual said to me, and I'm genuinely scared to come back to work. Actually hearing the voices of the people affected can be very, very impactful. I know when we pulled our report to push for the position, we pulled a lot of quotes, confidential quotes, but things that actually legitimately paint the picture of what people go through, right? Yes, you can say we had 15 completed assaults last month, but understanding that some of those assaults result in like broken bones and nurses just leaving the profession altogether, right? So understanding the realistic impacts and the representation of some of these incidents behind the nominal data. Looking at financial impacts, we had mentioned that as well, and you can get creative and clever with how you actually break down the financial impacts. Again, one thing that we worked for was burnout, turnover, the impacts of replacing a nurse. I think regionally nationally you're about 63,000. The Northeast, we're probably a little bit higher than that just because we pay a little bit better than the Northeast. However, understanding how much it costs to replace a nurse, right? So if we had 5 nurses leave because of a workplace violence incident, you can do the math on that, on what would be impactful. We can reduce our burnout costs and our turnover costs, injuries, all of that, right? Understanding actually how much this costs your hospital. And this isn't really easy data to pull. You got to dig a little bit for it, but it really, really can help make that case. Well, again, it kind of goes into injuries and trauma. When we decide trauma, it's not just the physical traumas that we typically think about, really looking into that emotional and psychological safety and the impacts associated with that as well. And that's really hard to put a number on. Staff burnout, we had mentioned that. Looking at training requirements, a lot of hospitals and a lot of organizations are starting to implement training as mandatory for workplace violence. And naturally, if you implement more training, you need someone dedicated to train it, right? What a lot of organizations do, will hire outside companies to come in and do their training internally, annually, multiple times a year, and it gets fairly cost ineffective. And we can go over training here in a while, but understanding that the more training you have, the more it's going to cost you. And if you have somebody internally who's able to do it, then that can really help make the case. The last one here is looking at your FTE reallocations. I know for us, we recently hired a workplace violence prevention coordinator for our home health care system that falls under Tufts Medicine, which is really great. We were able to do that, by making the case like we had mentioned up here, but also looking at their resources that they currently have. And if there are any roles that either could be combined, if they're not really that utilized anymore, if they have roles that have been vacant for a while and they don't look to refill them, perhaps we can relook at the actual position and reallocate some FTEs to more of a dedicated workplace violence prevention role. So a couple things here that could help you potentially make the case. And I know across our system, we've had a handful of successes implementing similar roles just by using some of these guidelines. All right, shifting gears, we'll really look into interdepartment collaboration. And I really, really like to talk about this one because, yes, we do have a dedicated workplace violence prevention role. However, that doesn't mean it's the end all be all, right? It's really the puppet master, so to speak, that this is their focus. They're dedicated to looking at workplace violence prevention, but they can't figure out all the solutions on their own. They really need that interdepartment collaboration. So another rhetorical question is, how do you communicate with each other and align initiatives? And we found this happening time and time again, where we all have similar goals, right? We want to keep ourselves safe. We want to keep our patients safe. We want to reduce injuries. We want to reduce assaults, restraints, and all that. And a lot of times, everybody was working on the same mission, but coming at it from a different perspective and a different way. And no one was really talking to each other, right? So the cool thing about the workplace violence prevention role is really, really fostering that interdepartment collaboration and being the glue between all of the different initiatives to really come at it as a united front, which is really nice. Typically, for workplace violence prevention, your public safety security teams have a heavy, heavy hand in it, as they should. When we talk about interdepartment collaboration here today, this is really above and beyond your public safety and security teams. It's looking at some other creative departments and areas within your organizations that can really help you foster that positive outcome. Starting out, really going over occupational health, employee health. Depending on where you work, you might have a different name for it. But it's really looking at the people who deal with our employees and potentially injuries and anything like that. For us, they've been phenomenal of putting a lot of our injury data together. Reporting can get kind of challenging sometimes for staff, especially if they're injured or assaulted and they're out of work. The occupational health team for us has played an integral role in really building those connections with employees that are actually affected by workplace violence, giving that support, and offering the committee and the workplace violence prevention team that injury data as well. They are historically didn't follow up on every single workplace violence event, and they do now. They'll comb through and sift through every abuse and assault report, reach out to employees in real time to actually give that touch point and offer them resources for EAP. And we can go over all this in a while as well. But occupational health has been a really great resource to have. We actually just taught a workplace violence prevention class yesterday, and a handful of the folks from the occupational health team were in it, which is really cool, like learning self-defense when they work up in Occ Health. Our chaplaincy team is really a phenomenal resource, underutilized in a lot of organizations when it comes to workplace violence prevention, and specifically that peer support and debriefing. Where a lot of things can go wrong as far as staff feeling unsupported is, okay, we give some mitigation strategies. Sometimes an incident still happens, and then a lot of times it ends there after the incident. Where the chaplaincy team has really, really helped us is fostering that post-event support. For years and years, we would have a peer support team. They're all trained in critical incident stress debriefing, which is phenomenal. But within that, it was really utilized for your other type of medical problems, right? So death of a child, death of a coworker. The debriefings that they would typically use didn't really incorporate workplace violence. So being able to collaborate with them effectively and look at their roles, look at their scopes, and now we really, really push for, okay, there is a workplace violence incident, there's an employee assault, either with or without injury, offering the resources there to have somebody to talk to has been really effective. And we've had a lot of staff that have taken us up on that. I know within the past year, we had a very, very challenging patient who was a nonverbal autistic patient, and her thing was trying to choke out our staff, and she got her hands around a handful of staff's necks. And after she was finally discharged and transferred to a different unit, we were able to pull in the chaplaincy team and go up and actually do a group stress debriefing there for them, which was really impactful for the staff to especially foster the feeling of being supported and just giving them the opportunity to confidentially talk about some of the feelings that they were experiencing. With law enforcement, if you have a great relationship with your law enforcement, that is wonderful. I find that not a lot of places have that. There's kind of that butting of heads when it comes to hospital and law enforcement sometimes. And I know we weren't, we also experienced that, we'll just put it that way, for years, right? Within the past year, we're able to actually reach out to our local law enforcement agencies and initiate a hospital liaison. So we meet with him very regularly. A handful of us have him on speed dial. So if something comes up, really having that resource in the community to look out to and really, really foster that community engagement as well has been really, really impactful. I know for us, a lot of staff would feel like they don't feel comfortable reporting incidents to law enforcement if there's an assault or anything like that. And again, this is the shifting of gears a little bit where law enforcement, even their narrative and their viewpoint is, yes, an employee is assaulted, they should report it every single time. And that's coming from the mouths of law enforcement. So we've been able to take that type of methodology and really put it on our staff and empower them to follow up with law enforcement, try to press charges, make a report with them at the very least if they feel empowered to do that. We don't want to discourage staff from doing that if they don't want to, right? So it's been really impactful being able to follow up on cases and actually engage with law enforcement. As far as clinical teams, we do a lot in the emergency department. We do a lot on the inpatient, the behavioral health side, but we also do a lot with the inpatient clinical teams. And one of my favorite collaborations that we have here, you can see the picture below of our child life specialist in the middle and her facility dog, sponsored by Dunkin' Donuts, but her name is Sophia and she's absolutely wonderful. Typically, she would work in the pediatric unit, working with the children and whatnot. But as a facility dog, we were able to actually meet with our child life specialist and broaden her scope a little bit to work a little bit more with our high-risk patients. If there's somebody who's safe to see a facility dog, and sometimes we found just bringing them in with, myself and my workplace violence prevention role. Sometimes just that individual who's in a high stress environment of just being in the hospital with anxiety and fear and all that, just by seeing a dog and being able to pet a dog was able to reduce a lot of incidents, which is really nice. And an added benefit for that as well, we would meet very, very regularly and look at where we had challenging incidents, either on the inpatient floors, the ED, and then bring Sophia to those locations to actually support our team and support our staff, specifically for workplace violence, which is really nice. And what's interesting is we do teach a lot of self-defense to our staff here as well. And we were able to meet with our child life specialist to go over some techniques to actually keep her dog safe. She was always concerned about if somebody were to grab Sophia's fur, how do you effectively disengage from that grab attack? So it was really that collaborative approach to make her feel safer bringing the dog in if she knew how to effectively disengage from any type of attack on her dog. So just interesting collaborations there that we've had. On top of Sophia and the facility dog, we do have a fairly robust pet therapy program where we have volunteers coming in with their dogs and their pets, making rounds, checking in with staff, and offering that support as well. With ALS, Advanced Life Support, one of the biggest projects that they implemented a few years back is the Behavioral Health Transport Program. So what they found is that a lot of times you would have that increased boarding of your behavioral health patient population for days and weeks, and sometimes honestly months, for the sheer purpose that they can't get transportation with ambulances. A lot of times they would prioritize your medical patients for reimbursements and whatnot, right? So what they were able to do is implement the behavioral health transport program where you had a handful of public safety and security officers who were able to go through and certify as emergency medical first responders to co-pilot the Chevy Tahoe that you can see below, and really transport our behavioral health patients to local inpatient behavioral health facilities, low risk patients, but nonetheless they were able to open up a lot of capacity within our emergency departments, our inpatient floors, just based on getting the behavioral health populations to inpatient hospitals that they needed. We do a handful of workplace violence prevention training with them as well. The behavioral health team, I know a lot of us have BERT teams, but the ability, if you don't, to implement a behavioral emergency response team is a really great resource. It's for a couple of reasons. Number one, they're really focused on this type of thing. They can de-escalate. And what I really like about the BERT team is they're able to take some of the load off of the primary nurse in the emergency department setting, inpatient setting. They can go in, they can set the behavioral expectations, they can administer medications. And then when they leave, that nurse can still have their positive and compassionate rapport with the patient. So within behavioral health, we do have our Sullivan unit, and I always like to bring this up. It's been a really, really great resource for us. So it's a 23-bed space. Out of those, 16 are typically used with seclusion-capable rooms. The other one's almost like a milieu setting for the other 7. So with that, every room has the ability to lock, secure. They have ligature resistant. The whole unit is ligature free, but they have ligature resistant TVs in the room. The beds are bolted down to the ground so they can't be used as weapons and things like that. But um, we've had 0 elopements since this is opened, which has been phenomenal because they have a sally port type setup where in order to get out the actual door, you have to go into more of an alcove where only one door can be unlocked at one time. So they're kind of trapped in there. There's no way to actually blow through one door and get out. So with the reduced risk of elopement, we saw a reduced risk of actual violence in there. And it's what's really, really nice about this space is typically the behavioral health patients would just board in the emergency department, which is really loud. It's really confined. It's fast paced. You don't get the TVs all the time if you're in the hallways. So taking those patients out of the ED setting and putting them more into a safe behavioral health space where they do have a specific room. They can close the door if they want to. They can watch TV. Reduce a lot of violence in the emergency department. And then subsequently, when you put them in some of these settings, violence will naturally reduce because it's more comfortable, more secluded, and a little bit more conducive to healing than your typical emergency department setting. With regard to our inpatient clinical teams, we've had a lot of support with them recently, most recently looking at type of resources like a violence prevention checklist integrated within an electronic medical record. We use the BROSET violence checklist, which has really positive impacts on predicting potential behavior within the next 24 hours and implementing solutions to try to prevent it. Looking at public safety and spending additional time rounding on the inpatient floors, getting notifications of violent patients, whether it's through the BROSET violence checklist or your violent flag as well. We send out daily reports to all the inpatient clinical teams across the board that show all of the high-risk violent patients that we have. If they have a history of violence, if they are scoring high on the BVC with that increased risk of violence, or your one-to-one patients that are potential elopement risks. We send that out to public safety and the inpatient clinical teams as well. One of the most recent projects is looking at our autistic patient population. And some of the violence that we would have isn't necessarily your overt violence, right? You don't have violent individuals. Sometimes you just have scared, anxious, fearful, overstimulated individuals where behavior is a result of their environment, right? So I had mentioned before we had that patient who would typically go after staff's necks to try to choke them. In looking at, her history, her background, her triggers, her trauma, talking to her group home, talking to her family members, we were able to collaboratively come up with a really good plan of care for her to understand what works, what didn't work, what are triggers, and then we can really curtail the care based on her needs. So looking at that as kind of a use case, we're able to standardize it, now implementing this whole autism awareness project where we have a worksheet here, and you can see all the data on the front that really helps give that specific care for the patient. On the backside, you have open spaces for notes that you can write anything that works for them. If you learn one day that they really like watching the Mickey Mouse Clubhouse, you can write that on there, right? You can write their schedule, things that really work specific to the patient. And then we have signage outside of the room with this internally developed logo as well, really to indicate for anyone going in the room, don't just barge into the room, right? Be mindful. Don't knock on the door really loud. Introduce yourself, keep the lights dim, close the door behind you, mitigate any type of sensory type of stimulations that could potentially cause behavior. So again, the inpatient clinical team, our child life specialist, behavioral health teams were really great collaborators on that. Like I mentioned before, we were recently able to implement a workplace violence prevention coordinator for care at home, which is our home health care umbrella that falls under Tufts Medicine. They serve over 100 communities in Mass, New Hampshire. They have a 21-bed hospice house up in Haverhill. So with that, a couple of projects that they were able to implement is give home health specific training with regards to entering the home. How do you effectively do that? How do you keep yourself safe? Parking ideas, right? Like what directionally, where to park when you're entering a home, what to scope out going into the home, anything like that. They actually have a really, really cool device here as well. It's called Invisaware. So you can see it's this bracelet looking device that's just very, very inconspicuous. However, it's essentially a GPS located active panic alarm. If you depress the button, it can notify 911, local law enforcement, or you can actually program a handful of individuals that receive a message as well when you press the duress button. For us, we have a handful of leaders over at the Care at Home, and then our workplace violence prevention coordinator, in addition to local law enforcement. All right, let's go into training a little bit. And again, another question for you is how do you effectively engage your staff in workplace violence prevention training? An interesting quote that I like to pull here is the healthcare and social services industries experience the highest rates of injuries caused by workplace violence and are 5 times more likely to suffer workplace violence injuries to all other workers, which is really fascinating. I heard 75% of all non-fatal assaults happen in healthcare, which is a lot, right? So it's really, really looking at that training and how we can foster effective training. So looking at different areas that you can actually train on. There's a short list here. It looks long, but it's short compared to all the things that you can actually train. But understanding what your issues are and where you want to focus your resources and focus your training. If you have a heavy behavioral health population, maybe look at specific behavioral health training with different diagnoses and specific strategies on how to manage people with, anxiety, depression, bipolar, schizophrenia, autism, things like that, right? However, if you're in more of an area that doesn't experience the behavioral health population, if you're more of a private practice, maybe you're looking more into calling for help, right? How do you effectively call for help if you don't have internal security and public safety? Training your staff on how to get resources there if they need. So looking at where your struggles are, where your challenges are, where the breakdowns are, and then implementing specific training based on that. And this doesn't need to be like a certification type training. This can just be in-service type education. So different strategies for training. There's benefits to all of them. Okay, e-learning is great. If you have a lot of people that you need to reach in a short amount of time and you can't necessarily do in-person training for 5,000 individuals, e-learning might be the best option for you, right? In person, I always recommend if you can do in-person training, it's the best type of training that you have. But I get there are sometimes where blended training is a really good option as well. If you can get the conceptual information out in more of an e-learning setting and then the practical learning in person can be very effective. I know for us, and there's a handful of organizations that have adopted a master service type of agreement with different certified workplace violence trainers, which is a really great opportunity if you can. So essentially, this gives you the opportunity to internally have master instructors and then train additional trainers, right? So if you go and adopt a master service agreement with any type of program, there's a handful that do it. But if we can be internally self-sufficient, that's where it's really easy to build out your program. You don't need to rely on external instructors to come in. You can train additional instructors internally and then facilitate any type of classes you need based on your needs. So for us, it was a 4-day master service instructor training, primarily on workplace violence prevention. Then I went through a handful of additional hours for home healthcare as far as master instructor. So with that, through the Tufts Medicine umbrella, we have 12 master instructors divvied up and allocated through all the different hospitals under our umbrella. And we now have a handful of additional instructors across the system beyond the additional 12 master instructors. So it's really given us the ability to roll out our increased in-person training. So I know when I first took over the role, I hit a lot of the in-person trainings with regards to orientation for nurses and techs and all that. And they use simulation training for crisis and de-escalation, which I thought was phenomenal. So I was able to shadow their program when I first took my role. This is when I was introduced to Fred. So I went into the simulation room and they had a mannequin, a dummy, who was sitting on the bed. And they said, this is what we use for simulation. And I thought it was really interesting because Fred doesn't yell, Fred doesn't move, Fred doesn't scream, Fred doesn't have emotions, right? So I asked politely, how do you do simulation training with a mannequin? And they just script it. So they have Fred, who's your simulated patient, with a staff member next to it. And we had a scripted conversation back and forth for your simulation training. Pretty quickly, Fred was no longer, and then we actually ramped up our simulated training. For workplace violence prevention, it's really hard to have a mannequin be your simulant because you need somebody with emotions. You need to be able to actually exhibit those emotions. And exert those emotions and feel them, right? What we found very, very quickly is that our participants, when we get realistic, real emotions in your simulation training, and there are some organizations that I know use like hired actors, and we had talked about there for a while. We strayed away from it because we want our actors to have also been in these situations and these experiences, right? It makes it a little bit more realistic if you yourself have experienced it. So, with that, we had a lot of our participants that are now not only responding to the external experiences, right, of your aggressor, your simulation facilitator, but also understanding how they manage stress internally. We found that a lot of people, their natural reaction to stress is to laugh, which really isn't a great thing in a crisis situation, right? So it's really been a phenomenal opportunity to make very, very realistic training with regard to simulation for emotions. And there's a handful of emotions that we've seen experience both externally, again, and internally within our individuals. A component before a simulation training is looking at the didactic training where we talk about weapons in healthcare, and there's a handful here that we really, really try to increase their environmental awareness in the simulation training. If we plant an IV pole in there and I'm pacing around the room, we look for them to actually identify that and remove it from the room. Things on their person as well that can be identified as a weapon, like stethoscopes or pens. We look to see how they manage those when going into the room. Another form of simulation training that we were able to actually implement is regarding safety search training, contraband instructions, and things like that. Here's a handful of images that we've had over the last couple of years, and this is just a small percentage of them, of things that we've actually experienced. The Smith & Wesson knife that's vaguely in the middle, I had pulled on me personally in the emergency department waiting room. So it's looking at our incidents and what we actually see and basing our simulation training on that. So for our public safety and security officers, we were able to implement this training with simulated contraband, which you have pictured on the right, that we put either in a backpack, we put in belongings bags, and we actually hide the simulated contraband where it would typically be hidden. Pairing that with, again, the verbals associated with it, right? Having somebody who's actually playing the part of a patient as they're getting their belongings searched has been a really, really interesting thing for us. And the cost of the organization to implement this was absolutely zero. It's a matter of going to the kitchen, getting some brown sugar and putting it in a bag, and going to your lost and found and finding an old backpack that nobody picked up and using that, right? So it's just a matter of creativity and looking at how you can use your resources that you have to fix some of the problems and breakdowns that you've experienced. With regards to intuitive weapons detection, and I know recently it's been a hot topic for weapons and weapons detection and metal detectors and all that. And yeah, I know there's a number of organizations that it's not really feasible to implement them, whether it's operationally, financially. So we kind of fell under that umbrella, but we still didn't want to let it go by the wayside, right? We wanted to still train staff on this type of thing to give them the tools and resources to build up that intuition for weapons. So this is a few slides that we actually implemented in a lot of our orientation trainings to be aware of potential weapons. So number one, talking about the neck knife, just the little things of teaching staff what a neck knife is. If they don't know what it is, they're never going to be able to identify and respond to it, right? So just identifying where people can typically carry weapons, looking for bulging, looking for fidgeting, consistently adjusting and touching. If you don't know these things, if you don't pick up on them, then it's really hard to identify it, right? Things like knife clips that are on your pocket, being able to actually observe that and identify it and call resources to facilitate the removal of it. And then looking at more of your ankle holsters, your boot knives and things like that. So just those few slides, we were able to implement in training with our staff. Within the first few months, we saw a drastic increase of calls for identified weapons. And again, this is within the first month or two of implementing some of this training with some of the weapons that we were able to take internally. Since then, we've probably done 3 to 4 more times this. I mean, we get a handful of knives on any given day just based on staff's observation, which is really, really wonderful. All right, we'll talk about program development and understanding your specific program and how do you get the most out of your workplace violence program. And we'll go through these fairly quickly, but looking at staff input, committee structure, high-risk area assessments, project development, data review, and closed-loop feedback. So looking at staff input, it's really good to foster that sense of empowerment for staff to speak up, to talk about what's going on, and using that data and information that you get to actually implement some of your strategies to reduce the risks of violence, right? So you can do this through reporting, through rounding, huddles, training feedbacks, and things like that. Now, taking that and looking at your community, your committee, who's involved in your committee? Is it just a small leadership group? Or do you actually include the boots on the ground staff that this actually affects day to day, right? How often do you have your committee meetings? If you have it quarterly, well, you kind of lose some things in between each meeting if you're doing it 3 months apart. So the more frequent, the better. I always recommend monthly. If you got to do bi-monthly, make sure you're meeting in between with subcommittees and all of that, right? Looking at your high-risk areas, if you can identify a few areas that this happens the most, then you can really allocate your resources appropriately. Otherwise, if you just do large-scale projects, it might not be as effective in some areas where you really want to potentially focus specifically on some of your high-risk areas. Now, with all of that data, the information, you have your high-risk areas, you have your committee structure, you can develop projects. And I'm talking about developing projects that are actually going to make a difference. And these don't need to break the bank all the time, right? They just need to be focused on the problem. And the problem can be the reality of safety, okay? So, for example, putting up a wall and putting up a locked door can really make people safer. What we find is that perception of safety is also real. When you talk about psychological and emotional safety, if your staff don't feel safe, then it's a lot harder to get them to either stay or be effective when it comes to crisis interventions and de-escalation, right? So fostering that idea of psychological safety and perceived safety sometimes can be equally, if not more important as actual safety there. Looking at your data, again, organizationally, you might have different data points on different things, but for us, it's really looking at our volume, where these are happening, who's affected, injuries, restraints, and everything like that. And once you have all of that and you implement your projects and you review your data, it's really, really important to go back to your teams and back to your staff saying, hey, listen, thank you for reporting. This is all the data we pulled. These are the specific projects we implemented. And this is, some of the outcomes that we've had, where sometimes when you look at, the reporting, if somebody puts something in and they don't give a closed loop feedback, then they might not be as inclined to report. Lastly, we're going to talk about staff support. So how are you supporting your staff before, during, and after crisis incidents? There's a handful of things that we've implemented, empowering our staff that you don't need to be the ones to go in physically control and restrain here at our organization, right? You have people for that. You have your public safety team. So being able to empower them to actually remove themselves from a situation, get back to the 4 to 6, 10-foot line for safety, and then calling for help. Not a lot of people knew that they could do that here, right? So if that's something you can offer as a resource for your staff, really empowering them to take a little bit of ownership in their personal safety. For anyone who has been assaulted at our organization, we do offer them a post-assault packet in real time, where we would give them a hard copy of what we call our post-assault packet that has a number of resources in it. How to step-by-step what to do guide after you're assaulted, with a handful of frequently asked questions and answers, how to report it both internally to law enforcement, return to work information, and the list goes on, but providing them that key contact information as well helps, again, give them resources in real time, but also gives that initial touch point with a nursing leader here. So within that, this is kind of what our post-assault packet looks like. We implemented our victim and witness information card as well, that allows them to confidentially give their information to law enforcement if they want to make a report with them without giving their personal home information. We also implemented our post-assault notifications. Again, this is something that you can do free of cost. There's nothing associated with it. But if you have an incident of an assault, having somebody who's dedicated to actually putting a little bit of a communication out to key stakeholders That way we can have that immediate follow-up instead of waiting to go into the safety reporting system or being notified days or weeks later to check in with your staff. It really helps facilitate that immediate follow-up response. So there's a lot of information really quick, but the really goal here is really just to look internally and formulate any type of solutions to keep yourself safe. And you do need to be creative with this sometimes. You do need to think progressively with this sometimes, but it is doable. It's just a matter of understanding what the need of your organizations are. So with that, I'll kick it back over to if anybody has any questions, we'll take them. More than happy to answer anything that you guys might have.
So while Whitney's setting up to put everybody so we can see them, we have some in the, let me read you a couple from the, one is, do you have any resources to share on the phone / virtual communications, escalation and de-escalation, and how to mitigate? So I would just say, are there resources?
What was there for? Was that on the phone you had said?
Yeah, it says, yeah, on virtual communications. Because I was, as a matter of fact, I was talking to somebody last week and she said, you're the nicest person I've talked to. And I didn't feel like I was as nice as I normally am because I was a little upset. But I'm thinking, I said, do you get abuse a lot? And she goes, every day. And so I think that's what that question is. How do you do that on the phone?
Yeah, and I'll say with this one that a lot of times, whether it's in person or virtually or over the phone, managing yourself is really important, right? Because that's really the only thing you can control. You can't control what other people say to you over the phone. You can control how you're responding, right? So to the best of your ability, try to separate and understand where they're coming from. Trying to still offer that compassionate type approach can really help. Sometimes listening is the best way to let people vent. It's always not what you say, it's how you listen. But I always empower our team and our staff here that, you really have no obligation to endure verbal abuse over the phone. So empowering them, if you are getting that verbal abuse, to respectfully discontinue the call. You really have no obligation to remain on the call and continue that. So that would be my best advice. And you can put that in policies, you can put it in procedures or just trainings as well.
And Tyler, would that look like if somebody's like being verbally abusive, that I stop and say, if you continue to speak like that, I will be hanging up on you?
Yeah.
That's not okay. All right.
Yep.
I just wanted to be clear about that.
Yeah.
Do
Absolutely.
we have any questions for anybody here that weren't put in the chat? Just either raise your hand or unmute and ask. Okay.
We do have a number of questions also. Oh, Maria, I know
Okay.
you put one
Maria.
in the chat.
Yes, thank you. So I actually put in the question about the resources. The reason for asking is because we don't often look at workplace violence when it is involving telephone or virtual, like, patient gateway or something like that. And yet our staff end up, in a situation where they are, dealing with the aftermath when they hang up that phone, if they're able to get the person off the phone. And there doesn't seem to be a lot of material and research around the outpatient setting and the communication piece. There's a lot of pieces from your presentation which were wonderful, and we can take back and try to formulate them. But from an organizational standpoint, what should an organization do to make sure that we have the right resources? Because that still is workplace violence when a patient gets out of hand to the point where they're affecting the psychological safety. But we should be training, we should be doing prevention, on not getting to the point of escalation. And I know basic communications do it, but today basic communications don't cut it anymore.
Yeah, and it can get really challenging because the amount of communication that we have that's nonverbal is the majority of communication, right? And it's sometimes you get an increased level of violence over the phone behind, closed doors in your own house where you can actually speak freely can get a little bit more challenging. So I know there's been a handful of organizations that have implemented a code of conduct and they proactively sent it out to people before saying that, if you offer any type of verbal abuse or threatening behavior or anything that will either just discontinue phone calls or discontinue actually having you as a patient and client. So more than happy to dig into that a little bit deeper if you like, if you want to reach out, we can touch base on that for sure.
I
Yeah, and
appreciate that.
Maria,
Thank you.
at
Yes.
the Betsy Lehman Center, we have resources for your staff to get support. So if you can contact us after, we'll have a
Great.
conversation with you as well.
Thank you all so much.
Okay. Whitney, do you want to ask one more question before we close?
Sure. A couple of folks had asked if you'd be willing to share your post-assault packet content. I know that they would like to use that in their own organization, so I wonder if that was something you'd be willing to share out.
Yeah, we've presented on it a handful of times. If anyone's interested, please just reach out to me. Specifically, as far as the full packet, we do have a copyright under Tufts Medicine. However, there's the bulleted list that we can get people to give them a little bit of guidance on actually how to formulate one for your specific organization. So yeah, by all means, reach out to me individually and we can connect on that for anyone who's interested.
So can we share his email address with people post?
Yeah, more than happy to. I don't know if I have it on this one. But yeah, email address, feel free to include it. Contact information, you can share that with whoever might need it.
Okay, perfect. And I want to thank you all for attending. And this is wonderful. And one of the things I was impressed with, Tyler, and I've mentioned this before, is your post-assault packet. Because usually we're teaching people the pre, but when it does happen, what do we do for them after? Because it can be very unsettling for the people that are working. And then to have to pick up the phone and do it again is really hard, or to the next patient. So thank you so much. Really appreciate that. And if you have any questions post, let us know. We may not have gotten to all yours, but thank you. We appreciate you being here. And please fill out the survey, because if there are other topics you're interested in, we'll certainly do our best to get people that will explore those topic areas. Okay.
Great. Thank you, everyone. Appreciate you having me.
Thank you, Tyler. We appreciate you.
Thank you.